received a Lifetime Achievement Award from the Advances in Neuroblastoma Research from the association, and another this past year for her international work in PSYOP. She initiated several landmark randomized trials in neuroblastoma in the COG, where she continues as senior advisor on the Neuroblastoma Executive Committee. She established the NCI-funded NANT Clinical Trials Consortium for targeted therapy of neuroblastoma, which she has led for 15 years. She currently chairs the Pediatric Solid Tumor Steering Committee at the NCI. She has been a leader in the development of targeted radiotherapy for neuroblastoma with MIBG, which she initiated at UCSF in 1987. And Dr. Matthay will be talking about COG and what current treatments are going on through the COG. Dr. Kate Matthay.
Thank you very much, Pat, for sponsoring this conference, and all of you for being here. Where do I change? Is this the slide changer? Okay. Thank you so much. And unfortunately, we haven't yet cured this disease, as you've heard from many of our parents today. And I'm a little sad today, as we lost one of our patients who I treated when he was 5 years old, and he died when he was 12 just this month from brain metastases. And it's sad. He had a good life despite that. He spent a lot of time at home. He traveled to Ireland several times with his family. He went to school. A lot of his treatment was outpatient. But I think the hope lies in the fact that we did keep his disease going through multiple relapses with some of the new therapies that we found through the Children's Oncology Group trials, as well as others. He got a lot of chemoimmunotherapy. He even got some very new targeted agents, BCL2 inhibitors, and he responded to every therapy, but then his disease came back. And I think in the Children's Oncology Group, we are really, again, trying to forge ahead to find out what we can do for high-risk disease. We'd like to, let's see, this is the next. We'd like to talk today very briefly about late effects of therapy, which you've heard alluded to, and I think you'll hear more about later this afternoon. And maybe if I talk like this, it's better. You heard about risk groups, and I'll talk very briefly about our intermediate risk neuroblastoma trial, trying to decrease therapy and decrease late effects, and mostly talk about our current high-risk protocols and plans for the future. So our late effects study looked at 377 patients who had more than 5 years of follow-up from diagnosis and had been off therapy for at least 2 years to be on this study. And we wanted to learn about what kind of organ dysfunction there was, secondary cancers, growth and development abnormalities, and also neurobehavioral or brain dysfunction after all this treatment. And this study has been run by Tara Henderson and Lisa Diller. So of the late toxicities, and this included patients who'd had single transplant, tandem transplant, immunotherapy, radiation, and isotretinoin or Accutane, and only a few with MIBG therapy, again, because that had mostly been given for relapse, and these were patients who had survived at least 5 years with their disease. So these were all high-risk, super high-risk patients. And the most common toxicity, which I'm sure you're all familiar with, was ototoxicity, hearing loss, found in 66% of patients, many of whom required hearing aids. Cardiac and pulmonary problems were lesser. Endocrine problems, including growth delay, short stature, hypothyroidism, and infertility were also quite common after all this high-risk therapy. Secondary cancers are deadly, but happily in a fairly small % of these survivors. So what can we do with all this? And our next goal is now to take these results and try to see how we can prevent them. Daniel just spoke to you about whether there are some patients where we can lessen the high-risk therapy. We would love to do that if we knew how without lessening survival. For the ototoxicity, the deafness, people are trying to learn if some more local therapy would be helpful, because we're worried that systemic therapy that blocked this drug would also block the anti-tumor effect. So this is just one example of ways we'll try to overcome, but I think we have a long way to go. So our non-high-risk ongoing study is called ANBL19P1 and Greg told you how these are named. So you can see this study was originally designed in 2012 and is still ongoing. And this was using both disease response and biology to guide therapy. And do you have a question? I'm sorry.
If you don't mind, sorry. Is TMA considered to be one of these toxicities, and is it something you track? How common is it, and is it something you're trying to prevent?
Yeah, TMA is a thrombotic microangiopathic angiopathy, is a very troublesome side effect that we see after transplant, both after single transplant and tandem transplant, and it causes renal dysfunction and breakdown of the red blood cells. It is not what I would consider a late effect. It's really an acute effect that comes on usually within a month of transplant. And there is a lot of study going on into what causes it. And we have an ongoing study at UCSF giving drugs to try to prevent it. But that is, it's not something we would see in the intermediate risk. It's really in the high-risk group who go through transplant. But it can be devastating because it can be ongoing for several months and it can interfere with your desire to give immunotherapy. So in this non-high-risk study led by Holly Meany and Naveen Pinto and then Jed Nuchtern, a surgeon, it builds on our prior study, and it's really focused on children who do not have MICN gene amplification and who are less than 18 months of age at diagnosis. They can have either localized invasive tumors or the 4S MS type of neuroblastoma, which occurs in infants with liver metastases and a little bit of bone marrow disease and skin. So in this study, as Ami showed you, we had an excellent survival in patients with very minimal therapy. It's better than 90% for most groups, except a little bit lower for the metastatic patients with unfavorable biology. So based on this, we did a new study to try to further reduce therapy for infants under 12 months who presented with localized L1 tumors, shown in the upper panel there, non-invasive tumors. We do not even do a biopsy. We showed in a prior study if they were less than 6 months of age with a small tumor, they did not need any therapy. These tumors would spontaneously regress. Now we've extended the age to 12 months, and we are also, as shown in red, studying not only tumors that arise in the adrenal that are quite typical, but also tumors that arise in the chest or pelvis. And those patients do not have to go through any dangerous procedure, no surgery, no biopsy. Then we are also, in a slightly greater leap of faith, looking at infants and toddlers under 18 months of age with more invasive tumors that we call L2. And you can see in the lower panel the cross-section of such a tumor arising between the kidneys and surrounding in white the blood vessels next to the liver and between the liver and spleen. And in the past, we thought these were unfavorable, but if these tumors have a benign appearance under the microscope, do not have MICN amplification or segmental chromosome abnormalities, we are now trying to avoid surgery, which can also have late effects in these very young children, and simply observe these tumors, and if they do not grow, they will not have any intervention. This part of the study is still ongoing. We still need to get more patients, as I think people are a little nervous about doing no therapy in this group. And then the other group on this trial are the MS patients with metastases to liver, skin, and bone marrow. And again, if they are asymptomatic and their tumors have all favorable biology, they are simply observed and we wait for the tumors to mature and go away. If they are symptomatic, which usually means they have trouble breathing because of a large liver which can cause compression of the lungs, then we immediately treat them with low doses of outpatient chemotherapy, and as soon as their symptoms resolve, we stop the treatment and observe them. Any tumors, however, with unfavorable biology would get chemotherapy until the tumors regress. So for the rest of the time, we'll be talking about what most of you are most interested in here, which is high-risk disease. In our ongoing open trial, 1531, led by Steve Du Bois, Emily Greengard, Tracy Easley, and our statistician, Arlene Naranjo, is trying to see if adding MIBG during induction chemotherapy will improve the long-term outcome. Additionally, for the first time, we are treating patients who do have a tumor with an ALK mutation with an ALK inhibitor right from the time shortly after diagnosis. So in this study, as it was designed, you can see at the top, the patients would enter on study here. They would be tested for ALK mutations, and if they have an ALK mutation, they would be treated, they were treated with crizotinib, the first generation ALK inhibitor, along with their chemotherapy throughout the treatment, and get standard induction, harvest, and tandem transplant, radiation, and immunotherapy. Patients whose tumors did not take up MIBG, which is about 10% of neuroblastomas, would go again onto standard induction and tandem transplant and immunotherapy. The rest of the patients who were MIBG positive were initially randomized between 3 arms, either standard treatment with tandem transplant, induction with MIBG after the 3rd cycle of chemotherapy, and tandem transplant at the end, or induction MIBG therapy and a single transplant with busulfan melphalan, based on some of the Cyapin data, where they felt that was a better approach than our consolidation. At the first planned evaluation by our data monitoring committee, we had to close the arm with busulfan and melphalan because those patients were actually having more relapses, doing more poorly. So currently the randomization is just between MIBG with induction and tandem transplant, or no MIBG. We also then decided to move to a better ALK inhibitor that works on resistant cell lines. So Yael Matthay and Kelly Goldsmith led a study in Nantes showing that lorlatinib, which, got my buttons mixed up. Lorlatinib, given in a resistant ALK mutation, could make all the animals survive with that ALK mutation, whereas crizotinib improved the outcome but was not as good, and with no inhibitor, the animals all died in preclinical work. So lorlatinib had been well tested in adults, and in the NANT we tested it in children, and are now testing it combined with chemotherapy and showed that it was tolerable. So we have now amended our study to give patients lorlatinib instead of crizotinib who have ALK mutations. And then in addition, as I said, we will no longer do the Bumel arm, and all patients will be randomized between these 2 arms. So we expect to complete this study, I think, in about 2 years, and hope to then, a few years later, have an answer as to whether using MIBG upfront like this will improve the outcome for patients. We are also trying to further improve our chemoimmunotherapy. We know that chemoimmunotherapy, as you see here in this study that was run by Rajan Modi in relapse patients, showed how effective giving dinutuximab with irinotecan and temozolomide much improved the outcome of patients, and we saw 40 to 50% responses in relapse patients compared to another agent given with this chemotherapy. So we are now trying to see if we can actually give this chemoimmunotherapy after transplant instead of what we are now doing, which is the antibody with just retinoic acid. So this is a small study for patients who are not on the current 1531 but have not relapsed and gotten to the immunotherapy stage. They will be eligible to get the chemoimmunotherapy. So they can't be on a different study, and they can't have had progressive disease. And they will then get their induction, consolidation with transplant, and then get temozolomide, irinotecan, GM-CSF, and dinutuximab for 5 cycles, and then get their isotretinoin as they do now. So really this study is being done right now just as a pilot to show whether this is tolerable after patients have had a tandem transplant and all the other therapy. So we hope that at least 75% of patients or more will complete 5 cycles of the chemoimmunotherapy within 30 weeks and have less than 10% unacceptable toxicity. This study only needs 40 patients to show it is tolerable, and we hope to complete it in 1.5 to 2 years. So far we have 22 patients enrolled, so hopefully in another year this will be completed. The other study, which Daniel mentioned, is our ANBL19P1 study, which is a randomized study for patients who've had first relapse. And this patient is looking at chemoimmunotherapy with the addition of DFMO. DFMO is an ornithine decarboxylase inhibitor, which an ornithine decarboxylase is very important in the pathway for MYC-N and stimulates cell growth and proliferation. So using an inhibitor, both in the lab and in a recent NANT trial, does induce responses and stop the growth of neuroblastoma cells. Also, Mike Hogarty has shown that DFMO alters the immune microenvironment, so it may have some kind of immunotherapy effect on the neuroblastoma as well. So for this study, patients must have either detectable disease by PET avid disease or biopsy or MIBG, and they have to be over a year of age and have no prior history of anti-GD2 therapy with chemotherapy, and no prior irinotecan and temozolomide. So this would not be for a multiply relapsed patient. This is for first relapse. So in arm B, the experimental arm, they get the DFMO for 3 weeks, and they get the usual 5 days of temozolomide, irinotecan, 4 days of dinutuximab, and the GM-CSF. So far, again, we have 51 patients enrolled, and this is a nice trial option where patients don't have to travel. They can get this at their home COG center. And we are doing many correlative studies to look at the mechanisms, the immunotherapy mechanisms. Another pilot, which has just completed accrual, is a pilot study to assess the feasibility and tolerability of chemoimmunotherapy. Again, you've heard allusions in many of the prior talks to starting antibody therapy with dinutuximab during induction instead of waiting till after transplant. And this has been a very promising approach in this single institution study at St. Jude's led by Wayne Furman and Sarah Federico. You can see the improvement in outcome shown in patients who received this chemoimmunotherapy right through induction as well as post-transplant, though in this study they also had some NK cell therapy. So based on this, as well as our success in our chemoimmunotherapy trials, we have done this induction trial pilot led by Sarah Federico and Wayne Furman, Susie Schusterman, to assess again the small trial to look at feasibility and tolerability as a basis for a new randomized trial. So here, unlike the St. Jude's trial, we are not starting dinutuximab with the very first round of chemotherapy, which could be a disadvantage, but on the other hand, many patients with high-risk neuroblastoma present very sick with a lot of pain, high blood pressure, and other problems. So we did not think it was feasible to immediately start them on antibody therapy. And so this starts after the first 2 cycles of treatment and the stem cell harvest. And then with the next 3 cycles, they receive dinutuximab along with their chemotherapy, have their end of induction evaluation, surgery, tandem transplant, and then standard immunotherapy. So all the patients on this pilot study have completed therapy. I believe this was presented at ASCO this year. And we showed that it is both feasible and tolerable, and it did not slow down or hinder any of the subsequent therapy. So based on this, we are in the midst of writing our new study, which was recently approved by the NCI to move forward. And this is ANBL2131. So this has moved pretty fast, was designed in 2021. And our hypothesis is that the use of chemoimmunotherapy during induction will improve the outcome in newly diagnosed patients with high-risk disease, builds on all the studies we've discussed, the relapse study, the St. Jude study, and our pilot. And it will be a randomized, controlled phase 3 study led by Thomas Cash and Sarah Federico, as well as Carrie Strebe and Naveen Pinto. And on this study, again, patients will, with high-risk disease, will come on study. They will be randomized right up front to be on the antibody arm or the standard arm. And after 1 cycle of chemotherapy, we will then add the antibody to the chemotherapy. And they will then go through their standard induction, have surgery, and so on. We have also, because we know all of you and we too are convinced that antibody is a very important part of therapy, and we don't want to deny children on the standard arm that option. So patients who do not have a good response will be eligible to cross over, which is a very tricky thing in a randomized study, but we will keep track. They will cross over and get a rescue with chemoimmunotherapy, as you see here. We do not have a written-in rescue for the patients on the antibody arm. They would go off study, but then be eligible to receive MIBG or other experimental agents. So this is our hope for the future, and hopefully this will get started. We won't yet have our answer from the MIBG therapy, but when we get that, I hope we can somehow combine these if the MIBG adds further. And maybe with this armamentarium, again, we'll be able to eliminate the high-dose chemotherapy for some patients. So I'd like to close here, and most of all, thank our patients and parents for their support. We would not have any progress without you, and we would not be happy as physicians without the joy of seeing our patients and sometimes making them laugh. It was always my challenge when I went into a room. And I'd like to thank Ro Bagatelle, who leads our neuroblastoma disease committee and graciously asked me to present this data for you. And our statisticians, the research coordinators, the institutional doctors who lead these trials locally, our reference laboratory, but also, of course, not least, Pat and the CNCF and all of you for your participation. Thank you.
Thank you, Dr. Matthay. Anyone have questions? Go ahead. Getting pretty bold now.
I know. It's 2 questions one day. Whoa. So our daughter is intermediate risk, and so I was wondering if you could kind of go into detail on what you guys mean when you say observe.
Oh, that's a very good question. Depends on how nervous we are. So it really depends on the patient's overall presentation. So an intermediate risk patient who is an infant and has a small tumor that we're not going to treat at all, we would usually, and who is asymptomatic, we would usually see that patient monthly at least, maybe more often the first few weeks when they're seen anyway. We would see them monthly, do urine catecholamines, do ultrasounds, and then periodically repeat scans. For a patient who was on chemotherapy with the L2 tumor, with the big tumor, again, I think we would, I believe the protocol calls for scans every 3 months. I would probably initially want to at least get ultrasounds every month again in those patients, since this is a new approach. And then we would periodically do MIBG scans in those patients, as those kinds of tumors we'd be more concerned about spread.
Okay.
I think, again, in the new thing we're studying in the newborns with neuroblastoma that arises in the chest, those patients have never before just been observed without surgery or biopsy. So I would be quite vigilant with their follow-up.
Okay. She's had 9 cycles of chemotherapy, and she just has a tumor in her neck. And so when we started, it had gone to the bone marrow, but now it's clear. So we're just treating the one tumor. But I'm obviously nervous to just watch her neck.
It is difficult, and I think it needs to be watched closely if she had spread before, but again, without seeing all the scans and biology,
Yeah.
I can't say, but I think that's what I was saying earlier to Dr. Yannick when I was asking about MIBG scans. In these young patients with favorable tumors, the MIBG often stays positive for a long time, even after the tumors are maturing. And sometimes, again, we get a PET scan to see if it's metabolically active and is likely to spread. So if I were concerned about something, that's a possible avenue of investigation.
Okay. So multiple types of scans, we would say.
If necessary,
Okay.
yes.
Thank you.
Anyone else? Another question?
This isn't directly part of your talk, but you did mention the microbiome. And I was wondering, could you explain the connection between the microbiome and neuroblastoma?
I can't.
Okay.
I mean, I think that's
there
a
seems to be a
wonderful
theory of-
There's
Tommy.
terrific research going on. We have a lot at UCSF studying the microbiome in relation to various diseases. I am not familiar with any of that in relation to development or progression of neuroblastoma. Did you have something specific in mind?
Oh, just that there seem to be some trials where there's medicines, even DFMO, that do something to the microbiome, and that's thought to help the disease. So I was just trying to understand what the theory was
I think there's definitely investigations going on, but I
Okay.
don't know of anything proven. But again, it's the bacteria that inhibit our body, and those can be good for us or bad for us.
Okay.
And we need to learn more about it.
Okay. Can I ask a second unrelated question, since that one didn't
Since
go
I didn't
too
know
well? I don't
anything.
know.
Okay.
When they do autologous transplants, what about patients like my son that had like almost 100% of the bone marrow having tumors in it? Can you explain why that shouldn't be a concern?
That's a wonderful question. And there was an early experiment from St. Jude where they marked the cells, the neuroblastoma cells, and they found that after the patient was transplanted, some of those cells were circulating. So a theory developed, or hypothesis was put forward, that when you do an autologous stem cell or bone marrow harvest, there are certainly going to be some contaminating tumor cells in there. And is that causing the relapse? So in our first transplant study that I actually led back in the 90s, where we showed that patients who got high-dose therapy and autologous transplant from their bone marrow had a better survival than those who got standard chemotherapy, we purged those bone marrows. In other words, we took those bone marrows out, we shipped them to a laboratory where they were treated with monoclonal antibodies to remove the tumor cells. And we did that to all the marrow. This was an expensive, you can imagine, and risky procedure. There was one child whose bone marrow was lost on the way, which was devastating. So we really didn't want to keep doing it. So in our next trial in the children's study group, we did stem cells because they give a richer harvest and they engraft faster, and that's why, and they're less painful to do. That's why we changed to stem cell harvest. We did stem cell harvest and we randomized patients. Half the patients had their stem cells purged with monoclonal antibodies against neuroblastoma, and half the patients got their stem cells back without purging. The outcome was identical. The relapse rate was exactly the same in both groups. So that didn't really answer your question, but what it told us was that the relapses we see are not just due to contamination of tumor in the stem cells, and the benefit of using the stem cells for this procedure was greater than going through the additional risk of a transplant from a different donor. We did test those stem cells by a more sensitive method called PCR, which I guess you all know because of COVID now too. And we found that even in the marrows that we thought were clean microscopically from doing very sensitive testing with monoclonal antibodies, by PCR there was probably still a little bit of tumor in there. And I know Brian and his group at Sloan Kettering have used that test for a long time to test for microscopic residual disease in patients. So they may be getting a little bit of tumor back, but we hope that we're cleaning it up with the immunotherapy. And again, because of graft versus host and other issues with allogeneic transplant, plus toxicity in the early trials, we've tended to stay with the autologous. In Europe, they are so worried about this that they will not do their harvest until the end of induction therapy, till they feel they've maximally reduced the tumor. Because of our approach with tandem transplant, we prefer to do it after just 2 or 3 cycles, when most patients have reduced the tumor in their stem cells to the point that we don't detect it, because we get many, many more stem cells and have reserve in case for tandem transplant, for MIBG therapy, or other rescues if the patient relapses.
You don't think that's related to that whole like Curie score greater than 2, though? Maybe it wasn't broken down by the patients that, they didn't analyze it by like patients that might have had bone marrow
Oh, no, but again, on that original Curie score paper, that was from the study where we tested all the stem cells for tumor. And we did not use any stem cells where we detected tumor by what's called immunocytology. So we didn't analyze in that way.
Can I just comment about two things? Microbiome. At Sloan Kettering, we have a laboratory dedicated to studying the microbiome. And we're studying our patients with neuroblastoma and their microbiome. And it's an important part of our evaluation because certain profiles of the microbiome are shown to boost your immune system. So if you're doing therapies that are based on the immune system, for example, antibody or vaccine, the microbiome is of some interest. And some of the, I'll refer to it just briefly in my talk. If we get to that slide, it's further down the road. But the microbiome is a big concern of ours, and we're finding some really interesting results in our evaluations. And number two, in terms of collecting stem cells, I'll talk later, we don't transplant, but we do collect stem cells. And unlike in COG, they collect stem cells after 2 cycles, the same combination of chemotherapy. We always collect after at least 3 cycles. So the patient's already been exposed to 2 different combinations of chemotherapy, one of which tumor cells might be resistant to one, but not to the other. So maybe it's a better chance of having less occult or hidden neuroblastoma cells in the stem cell collection.
Thanks, Brian, for the information
we
on
get
the
lots of,
microbiome.
we get tons of cells anyway. And there's another reason why we collect after 3 rather than 2. When you collect stem cells, it takes some time. And we want to get our chemotherapy in as soon as possible, including the combination that's going to kill cells that were resistant to the first 2 rounds. So we don't want to defer that. And I'll mention that something called the Goldie-Coleman hypothesis of rapid administration of chemotherapy reduces the chance of spontaneous mutations that can confer resistance. So there are 2 reasons at least why we collect stem cells after 3 or more cycles of chemotherapy rather than just 2.
Okay.
Thank you.
All right. Anyone else have a question? All right. Last one. All right.
Last question. Okay, on the studies that you mentioned, quick question, are there any preliminary results on the ANLB or ANBL19P1? That's one. And then every time I ask Dr. Marichelli and she comes in the clinic, she's like, no, nothing yet. The second one is, I know, today's the day. Does adding, or is there any initial data that adding MIBG therapy before bone marrow or stem cell transplant could cause more complications during stem cell transplant?
Thank you so much. In answer to your first question, we have an independent data monitoring committee that monitors all. You have to have it on any clinical trial, and of course we have it on all our COG trials. And they do look at the data that we running the trial are not allowed to see. So there may be some data on 1821, but what I can tell you is if there's anything that tells us we should change, for example, put everyone on DFMO or stop DFMO because of an adverse effect, they would have stopped the trial. It's so interesting because in a recent COVID trial, they were testing vitamin C and the trial was stopped because they actually found the vitamin C arm did worse. So these data monitoring committees are very important, and that's what stopped our current MIBG trial, stopped the busulfan melphalan arm, not because of toxicity, but because more patients were relapsing or not responding. Your other question, I'm sorry, was? Oh, yes. So we did, Greg Yannick showed you a couple of the early trials we did putting MIBG right with transplant. And what we found was there was maybe a very slight increase or proportion of patients who got a complication called veno-occlusive disease, but it was very small. and did not hinder us going on. We then did a large multi-institution pilot trial in the Children's Oncology Group where patients got induction, then got MIBG therapy, and then got a rest, and got about 6 to 8 weeks later, got high-dose therapy and transplant. And we actually, this was based on a pilot from Europe, but they never published their data. And when I went back, it turned out they were giving patients a much longer rest than we had put in. And we were, again, had a couple of bad veno-occlusive disease patients. So we prolonged the rest. And in the end, we decided it went fine. Patients did not have too many complications. We showed it was feasible, but we didn't see a great outcome in this pilot study. And we think it was just what Brian was talking about. When you have a long gap in therapy, it's not a good thing with these patients. And that's why we decided to move MIBG therapy up early. And we have, again, with the blessing of the Data Monitoring Committee, we have not had an increased risk of adverse events so far or toxicity on that study. And there are some small pilot trials done in Europe at single institutions where they gave MIBG right from the beginning. I think Greg or Daniel mentioned one of those. And one of the nice things was it seemed to shrink the primary tumor dramatically so that they were getting better results at surgery. And that was one of our hopes by putting the MIBG earlier in induction. Thanks.
Okay. All right. Thank you very much, Dr. Matthay. We'll go ahead and take a 15-minute break. I think there's pretzels or something like that out there, some soft pretzels. So see you back here in 15.